So this is my vlog for rehabilitation. So my client is 81 years old. She's a female. Her past medical history is she had open heart surgery about 5 years ago to replace a valve. I think it was an aortic valve. She's also had a heart attack 2 months prior to me seeing her about this issue. She's also legally blind, and she has been since she was 65, she says. So her history of present complaint. So she has slight back pain, and says it's been going on for 4 or 5 months. So I believe it's chronic pain, as it's past the state of healing, and it's still continuing to be a 10 out of 10 VAS score, she says, when she tries to stand up, as the pain is when she's gone from sitting to standing. So basically lengthening or using her glute. She also says it hurts when she tries to sit down, so lengthening her hamstring. So sitting in a squat position, that's where she says it hurts the most. So she said 11 out of 10, but take that as a 10 out of 10 worst pain. So her activities in the day, though, she's very sedentary. She sits in front of the TV most of the time. She'll cook in the evening, but she doesn't leave her house. She's actually the carer of her husband, who's 90, as he's got a disc problem where it is pushing on his nerves that go down to his legs. So there's a pattern with nerve pain in the family, but yeah, so she looks after him as he can't walk very well. But she actually had a scan just to have it double checked, and they said that she has degenerative disc. So she's been cleared of all yellow and red flags, so that's good. So for my objective assessment, I ended up double checking how her pelvis was tilted and her creases of her knees, and her arches of her feet and her ankles and her Achilles, just double check that she was in line, which you'll see in the video. I actually couldn't do a range of motion or muscle strength test, as she didn't want me to show the video to anyone. She was a bit uncomfortable, so I'll insert a video of me doing the test on someone else, just to demonstrate the tests. So just asking the patient now that I'm gonna assess her hips, and I'm telling her to turn around so I can check her PSIS and ASIS. And as I pushed down on her lower back, she said that hurt. So on palpitation, her lumbar spine actually was painful when I was trying to find her PSIS. And actually, when finding her ASIS and PSIS, she had an anteriorly tilted pelvis. So she actually gets a lot of stretch in her hamstring, she said, and that they feel really tight all the time. So that could be a cause of that, and it's also because she also sits down every day, so that could be a cause for the anteriorly tilted pelvis as well. I then go on to check her creases of her knees, which are even, as well as I then go down to her ankles to check her Achilles, which are both straight, as well as checking her arches of her feet, which they seem normal. They weren't flat, they were just slightly turned in, but not a lot. So with my patient, I'm going to go through active and passive range of motion of the hip, knee and ankle. So I'm just doing hip flexion at the minute, doing active and passive. I'm now doing knee extension, and now I've asked my patient to turn over so I can do hip extension. So I'm just holding on so he doesn't cheat, but I'm doing it as a long lever and then demonstrating that you can use a short lever by bending your leg, so if that's hard for your patient to do. And then I'm doing knee flexion, active and passive, as well, and dorsiflexion and plantar flexion, and seeing if you can go any further or not. I also do inversion and eversion, and then move on to hip adduction and abduction, where I fix the hip so that they don't cheat. So my patient, who didn't want to be filmed, she had a limited range of dorsiflexion, but other ranges, so a hip, knee, and inversion and eversion were all fine. It was just she had a limited range of dorsiflexion instead. I then move on to resisted muscle tests, so I'm testing his dorsiflexion and plantar flexion at the minute. And then move on to eversion and then inversion. I then move on to knee flexion and knee extension. I then move on to knee flexion, so I'm just moving back so then he pulls up. Same on the other side. And then I'm moving into hip, abduction and adduction resisted muscle tests. So my patient actually was very weak in all of this. She actually couldn't do a lot, but she was the same both sides, so she was weak both sides as well. So I'm also moving on to hip extension with a short lever and a long lever. So here I'm just asking the client if she can lift her leg up to a good height, just to double check if she actually can do the test on the bed. And then I'm just now telling her how to actually do the test, so putting your chin on your chest and your hands behind your back and then lifting your leg up, and then for her to lift her head up, so just to see if it eases off. So I've just asked her if there's any pain. She said yes, and it said it feels tight, and then I asked her to lift her head up, and actually she said it eased off now. And then we go on to the other side, and I asked her to do that, and she said it feels really tight in her hamstring. She said it's pulling on her glute, and then she lifts her head up and she said it's still there, whereas on the other side it says it eased off, so that would mean it was positive on the left side for nerve pain. But in the next video I'm going to do some extra tests just to double check if it's down the leg or it's just in the bum. So now in this video I'm checking down her whole leg, so her tibial nerve and her peroneal nerve. So first I'm doing her peroneal nerve, so I'm dorsiflexing and everting the foot and then bringing it up, and then asking her to move her head side to side, see if it eases off or not. And both her tibial nerve and peroneal nerve was positive on her left side, so she got nerve pain going down to her foot when I plantar flexed and everted, which is the tibial nerve. But when I did her dorsiflexion eversion, that did not trigger her pain or pins and needles or anything. Whereas on the right side, she just said it felt like a stretch. It didn't feel like it eased off or anything. So that means it was positive for a nerve test on the tibial nerve as well. As well, I videoed the patient walking, and as you can see, her right foot turns out more like ballerina feet, and then as well, her right foot also comes in front foot like a straight line, whereas her left foot goes out to the side. So it's sort of an abnormal walking pattern. So my patient's problem list from the whole objective and subjective assessment is that she got pain or palpitation walking, she had her right foot would become central, whereas her left foot would just stay on, like, underneath her. She had an anteriorly tilted pelvis as well as reduced dorsiflexion. She also had weakness all over her lower limb, so she wasn't very strong at all. She also had nerve pain that comes down her leg, on her left leg. So, starting with pain or palpitation in her lower back. So actually 36% of elderly people get lower back pain, and it's very painful. So what my patient described it as a 10 out of 10. So that makes them highly sensitive to tests as well as like standing or sitting. This is mainly from degeneration of the spine, which are quite a lot of people will have degeneration of the spine. So it's not a cause of the nerve pain, but it could be. However, another cause could probably be that she's very sedentary, as she's blind, as she's a carer for someone else as well. She actually doesn't walk a lot. She only stays in the house, so that could be a cause for it as well. So, speaking about her walking and anteriorly tilted pelvis as well as her reduced dorsiflexion, so her walking is probably caused from her pain, as she's compensating for it and trying not to hurt herself. So she's sort of swaying a bit as she's walking, but also that could be because she's blind, so she actually can't see where she's walking, so she's used to that pattern. So her reduced dorsiflexion as well. She said that she also gets tightness in her calves and her hamstrings, which she felt on the nerve test that I did on her. But she could, on her left leg, the pain was nervy, whereas on her right leg it was just all tightness. So I suspect this is probably from her anteriorly tilted pelvis, which can be caused from a sedentary life, as sitting for long periods of time can affect the pelvis. But that will also, because of the sedentary life, it will also give her a decreased amount of weakness. So she's very weak all the time, which isn't very helpful. So standing up is a struggle for her. So that as well. So her nerve pain, I think, is from the sedentary life as well. But it could also be from her degenerative disc. So they didn't find a disc bulge or anything pressing on the nerve. It literally could be that she's sitting down for too long. As you can see on the sciatic nerve runs under the ischial tuberosity. So that's your sit bone basically. So she is sat on that constantly, and she always says that it's bruised when she's sat on it and that she gets pain in her bum. So that can be from her actually sitting on the nerve and compressing it that way, because after a while when she's moving and everything, it sort of eases off. So my goal for her is I'm going to try and get her to walking a lot easier, and standing up a lot easier, so that she doesn't get as tired or doesn't feel as much pain. Because as well, chronic nerve pain can be decreased by physical activity within the elderly, which a study has in 2013 was done. So I will give her quite a few exercises and goals for her to do. But a goal for her I've set for her is to do more walking in the day, so about 1,000 to 2,000 steps in the day. So she's got a walking monitor on her wrist now, that she's going to wear as well. So a regression of this exercise is having the patient go off a higher chair, so it's easier for them, or a progression would be for them without the walker, what you can see here, or from a lower chair. So a progression for this exercise is for her to do without the walker, so to do it against gravity, or to have weights, which would be a further progression. So a regression for this exercise is she could be on her seat at the edge, doing calf raises. A progression of this exercise could be that she does it off of the stairs instead, holding onto the banister. So progression for this exercise is actually she could be sat in her seat and adducting both her legs at the same time whilst holding onto the seat, or on the floor as well. So progression of this exercise is I could put weighted cuffs around her feet, so she has more of a resistance, or to do it with a resistance band, so I hold the band and she has to pull up. As well, she could do it with a machine in the gym. So actually, when I assessed my nan, this was 3 weeks after she'd done some exercises, so she's a lot better, and they've actually just moved into the new house. So thank you for listening.